Thank you very much. I'm going to spend just a few minutes talking about energy considerations for pediatric surgery, but I'm not just going to talk about using energy for children. I'm actually going to give you the opportunity to test some of the things that you've learned so far in this lecture, or in this series of lectures. So I have nothing to disclose. So you can't give the pediatric lecture in a series without mentioning that children are not small adults. And some of you who were here earlier in the week may have seen me running around with this very person who looks like a mini version of me, and she is in all the best and worst ways. But if you are considering operating on her rather than me, she has some unique, and all children have unique anatomic and physiologic characteristics that you need to take into consideration when you're using your energy devices. You may say, well, this isn't really relevant to me because I don't operate on children. However, I would challenge all of you to think that you do, in fact, operate on people with anatomic and physiologic variations. So many of you will operate on folks who have one or more amputations, or who have implanted devices, or who say may be very edematous, either from renal disease or severe sepsis, and those variations need to be taken into consideration when you're using energy devices. So let's talk about what's different in children and think about how that applies to your patient population. So number one, compared with adults, infants and children have a much greater body surface area ratio to volume ratio, but in fact have less total body surface area. So less surface area means less space, less real estate for all of your monitoring devices, your electrodes, your dispersive electrode especially, and then the place you need to operate. In addition, when you have less surface area, it means that you have tissues that are high resistance in close proximity to tissues with low resistance, and so the path for your current flow may be much less predictable than it is in adults. Now, you've learned so far that tissues that have higher water content also are greater conductors of current, and children have a lot higher water, or infants especially, have a lot higher water content. So an adult actually has about approximately 60% total body water, as most of you know. A newborn term infant has about 70% total body water, and if you are operating on a term infant or an extremely premature infant who is small for gestational age, they can be as high as 90% total body water, which makes them great conductors of current. In addition, if you are operating on a person that is smaller or a smaller area, any injury can be catastrophic just due to the small size. Now, we've talked a little bit about operative fires, which is the extreme thing that everyone wants to avoid. The small airways that occur in infants and children, or maybe some of your patients who have smaller airways due to disease, reconstruction, stenosis, these are set up for operative fires. So you're putting together combustible materials and an oxygen-rich environment in a very limited space. So in these situations, there are precautions that you can take. Ideally, you use an appropriate size cuffed endotracheal tube to separate your upper and lower airways and the source of your oxygen. But in younger children, we don't use cuffed endotracheal tubes, so it's really important to make sure that the tube that you use is an appropriate size to avoid a large leak. Now, in addition, you want to use the lowest oxygen concentration that you can use safely, but many people who are operating on both children and adults will have patients with comorbid pulmonary or cardiac conditions where you do need to use a high concentration of oxygen. And in these cases, if you are operating in an airway, in the oropharynx, or even if you're operating on a thyroid or the head and neck, you have to be very careful with those high concentrations of oxygen. And in those situations, you want to always, as you've heard over and over again, use the lowest possible settings that you can use that get the appropriate thermal effect, but you also want to really consider not using those high voltage modulated waveforms, your coag, as opposed to the cut, because those coag settings, that coag waveform is very prone to sparking. All right, one of the things that I have never seen written down, even in any pediatric surgery textbook, is what said electrosurgical energy settings that you should use in children. And this is something that I actually joined the Fuse team to find an answer to that question, and I still don't have one. What I will say is that the maximal recommended settings for electrosurgical generators will vary by device. And in general, in pediatric surgery, we use much lower settings than people typically use in adults. So for a preterm infant or a newborn, I will use settings of 8 to 10. For a term infant or an older toddler, I'll use settings of 10 to 12. And I do operate on 500-gram premature infants, but I also operate on 300 and 400-pound teenagers, and I rarely use anything higher than 15. So I would challenge all of you to rethink the energy settings that you are using and whether you actually need to be using things as high as 25 or 30 for the larger patients. What I will say is that if you are in a hospital that has to operate on children in emergency, you're an adult surgeon and you have to operate on children in emergency situations, you do want to make sure that your specific devices are calibrated and that you know the maximal safe settings if you're operating on, say, a 5-kilogram infant. And this is something that does require, with a new device, an engineer to come in and tell you what that setting is. And some of the manufacturers will make stickers that can be put on the side of the devices. You will sometimes see those in children's hospitals, but often not. The rules for dispersive electrodes and where to place them are the same for children as they are for adults, and as always, you want to choose a well-vascularized site, something that is close to the surgical site, but does not contain bony prominences or any implants or scar tissue. I will reiterate some of the rules because it is just more challenging in children. Dispersive electrodes are available in weight-based sizes for infants and children, so the lower limit of this is about 400 grams or about a pound. You can use adult dispersive electrodes when children get up to be about 30 pounds or 13 to 14 kilograms. Again, it is challenging to choose an appropriate site, and I will warn all of you, if you do find yourself in a situation of operating on neonates, that adhesive on the dispersive electrode can be very tough on their fragile skin. I've run into a case once where I could not get a dispersive electrode to stick appropriately or to develop appropriate contact on a preterm infant that required emergency surgery, and in that situation, I used a bipolar device, which was very effective. The preferred sites for babies, in a neonate, you want to put the dispersive electrode on the back between the scapula and the sacrum. In an infant or a larger infant, you can put it on the back, on the torso, or sometimes on a thigh. And the rules are the same for children as adults. You cannot cut or modify that. You don't want to overlap with any other electrodes, and you want to make sure you don't have contacts with any patient leads or cables. I think one of the more challenging things in infants is protecting that dispersive electrodes from fluids. So almost any site in a baby is at danger of drainage from irrigation or fluids from the operative site. And if you do partially detach that dispersive electrode, it can become an active electrode, and if you have that on the back of a baby, that will create a circumferential burn that will kill them. So what I do in operating on the abdomen or chest of children is use, or really any site, I use adhesive drapes that are fluid resistant and protect that operative site as well as protect the dispersive electrode. This also helps to keep the infant warm. Finally, to talk about our smallest patients, the fetus, there is no evidence that using electrosurgery in a pregnant woman poses any risk to the fetus at any stage of development. This is because that electrolyte-rich amniotic fluid is going to protect the fetus from concentration of current. And as you've learned earlier, the output of electrosurgical generators is above the level that stimulates muscle contraction for both adults and the fetus. So the only real risk to the fetus is if that fetus is directly touched by an active electrode during a C-section or during fetal surgery. All right, I'll take any questions.